Good morning. My topic is about DALK for pellucid marginal degeneration. Peripheral corneal ectasia continue to pose challenge in diagnosis and in surgery. Today, I'll try to share our experience with deep anterior lamellar keratoplasty in pellucid marginal degeneration, with emphasis on rational surgical considerations and clinical outcomes. To frame the discussion, I will begin with a brief review of pellucid marginal degeneration. Pellucid marginal degeneration is a non-inflammatory corneal ectatic disorder characterized by inferior peripheral corneal thinning, typically reserving the limbus, while resulting in high irregular astigmatism. Pellucid marginal degeneration has a high impact on visual acuity due to these structural change, resulting in clinical presentation and surgical implications. PMD, pellucid marginal degeneration, or PMD, is less common than keratoconus. It has a slow progression and predominantly affects cases in the younger and middle-age groups. There will be an inferior peripheral crescentic shape thinning at the inferior part of the cornea. Typically extends from 4 to 8 o'clock. In PMD, there will be protrusion above the thinned area. So there is a thinning and there is a protrusion above it. So this is in contrast to keratoconus, in which the thinning is at the central or paracentral area. That's at the point of thinning. As you can see here, there is an inferior thinning and there is an apical protrusion. Clinically, these patients present with progressive visual distortion resulting from the high irregular astigmatism. And typically, there will be, as I said, the thinning will be inferiorly and the protrusion is above it. But there is no scarring, vascularization, or lipid deposition. On slit lamp examination, it's clear you can see the inferior thinning and there is apical protrusion above it. And it's not uncommon for those patients to present with acute hydropis. So the key diagnostic clue is ectasia above but not at the thinnest point. And this a key distinction from keratoconus. While the clinical features aid in diagnosis, but imaging still required to prove the diagnosis, and topography is the gold standard in diagnosis of PMD. So the topographical features will show peripheral steepening, superior flattening, and all these, with the inferior thinning will constitute what's called the crab claw. So this is one of the classical pictures of pellucid marginal degeneration. Anterior segment OST will also help in aiding in diagnosis and showing the thinning, which is located inferiorly and has also important during surgical planning. The management strategy depends on the clinical stage of the disease. In patients with early to moderate disease, usually they can be treated by glasses or contact lenses. Corneal cross-linking has been used to decrease or to halt the progression of the disease. However, it's not with, it's challenging because of the inferior location of the thinning, and also it requires a modified protocol. Surgery for PMD is usually indicated in patients in whom the optical correction is failed or the corneal integrity is compromised. And of the surgical option, we have intracorneal ring segments lamellar techniques like deep anterior lamellar keratoplasty or penetrating keratoplasty. Why we choose DALK for cases of pellucid marginal degeneration? Because DALK preserves the endothelium and minimizes the rejection, in addition to faster recovery and excellent long-term survival. So this video shows big bubble in a case of advanced PMD. I choose to do a trephination in an eccentric way so that I can involve the inferior stiffening in the trephination. And I used about to refine about 70 to 80% of the cornea. Big bubble is used in the same way like in cases of keratoconus. And then the anterior stroma is removed in the usual way. Then, after removal of the stroma, a host cornea is used after removing of the decimate membrane and suture with 16 sutures. So despite the challenges, there are certain challenges of DALK in PMD, and most important is the peripheral thinning that might result into a perforation during the surgery. That's why it requires careful trephination. And it's also there will be a residual astigmatism and suture problem that should be kept in mind while during the follow-up of these patients. Despite these challenges, the results or the outcomes are rewarding. Our results are in line with the reported series that have shown that there is a visual improvement in 70 to 80% of cases in patients with PMD who have we used the surgery, the DALK for them. And there will be also a significant reduction in corneal astigmatism, in addition to the very low rejection rate. So, to show those clinical outcomes, I will show a number of cases for which I have did DALK. For example, this 31-year-old patient who was contact lens intolerant, his vision was 5/60 in the left eye, with topography showing advanced classical pellucid marginal degeneration. So after surgery, doing DALK using the big bubble technique, post-operatively at 6 months, the patient had a best corrected vision of 6/12, and the Kmax dropped from 61 to 47 diopter. That is a 14 diopter change in the Kmax, with significant regularization of the topography. So this was the cornea case, and this the topography showing the improvement in the topography of the same patient. This is another case of severe PMD treated with the same technique, that's big bubble, DALK with big bubble technique. He also showed great improvement in the vision. Post-operative, he had, after removing all sutures, he has a 6/9 partial with correction. In patients in whom a big bubble cannot be achieved, an alternative is to do blunt scissor dissection. It's a good alternative in patients in whom the big bubble will fail. So this patient had also moderate PMD in his right eye. While the big bubble failed, we changed to blunt scissor stromal dissection technique. And surprisingly, the vision was very good. Post-operatively, after removing all sutures, the patient was 6/9 with correction. And you see the regularization of in the topography, and also reduction in the astigmatism post-surgery. So this one of my patients, you see the great change, 8 diopter to 2 diopter cylinder after the surgery, and the left eye from -12/75 to -3 diopter of astigmatism. So in conclusion, DALK is considered to be or provide consistent visual and topographic improvement in patients with advanced keratoconus. It provides excellent visual rehabilitation with very low rejection risk. And in patients, while in DALK, careful patient selection and meticulous surgical technique will make the DALK one of the primary surgical option in patients with advanced pilocytic marginal degeneration. Thank you for your attention.
Thank you very much.